All right, everybody, welcome back to Medical Biochemical Clinical Course Seminar Series. It's October 21st, 2022. It's week 14 of the series, and we're happy to welcome back Dr. Bill Wilcox from Emory. He's going to be talking about lysosomal storage diseases. This is the second part of his lecture, so if you haven't heard the first part, we have it archived on the SIMD website. You're welcome to go back, listen to it, watch it. It's fantastic. So looking forward to this one. As always, everybody should remain muted if you're able to. If you want to chat in the chat, please feel free to post comments. And then questions at the end, obviously you can unmute yourself. Jade just posted the CME code. I'm going to be reposting it a couple different times throughout the lecture for anybody coming on later. And otherwise, next week we have Dr. Curtis Coughlin coming on to talk about glycine and lysine metabolism. So that should be a good lecture. We'll talk about pyridoxine-dependent epilepsy, non-ketotic hyperglycemia, and a couple other conditions. So stay tuned for that. Dr. Wilcox, if you're ready, I will hand it over to you.
You bet. Thank you. Here we go. If this thing will advance, please. Okay. We're going to talk about neuronal LSDs today, and this is modified after last year's talk. I've updated some things. So the reasons we would suspect that you might have one of these is a loss of developmental milestones, behavioral changes, psychosis, seizures, ataxia, neuropathy, neuropathic pain, macrocephaly. In the eye, corneal clouding, ophthalmoplegia, usually vertical, and retinopathy. And so this is not the ones that involve lots and lots of other systems. That's not what we're concentrating on. It's mostly ones that are the brain. GM2 gangliocytosis is autosomal recessive. And what you need to know about this, and this I'm sure will be on your boards, is hexosaminidase A. It comes from two subunits from two genes, hex A and hex B. It's an alpha beta heterodimer. It will degrade GM2 after it has been presented by the GM2 activator. So it's a separate gene that encodes that. And it will remove terminal hexosamine from GAGs, glycoproteins, and glycolipids, like its counterpart hex B. Now, hex B is made up is a homodimer of the beta-beta subunits. So that's all from one gene. So there's two different diseases associated with this that cause GM2 gangliosidosis. One is hex A deficiency, that's known as Tay-Sachs, and that's storage of GM2 gangliosides in the brain and nerve cells, but not much else outside of the nervous system and the eye. Sandhoff is deficient in hex A and B, and has more non-CNS manifestations, at least in the severely deficient types. So what we're talking about is all the way up here. These are complex gangliosides get broken down. We'll talk about GM1 in a minute. And then this GM2 has to get broken down by this hexosaminidase A with the GM2 activator protein. The Sandhoff also degrades this beta hexosaminidase, this GB4, which breaks it down to GB3, and we're in love with GB3 because that storage that causes Fabry disease. So infantile Tay-Sachs, they appear normal at birth, but have storage in their brains, and they get loss of their motor skills starting between 3 and 6 months, with weakness progressing in an exaggerated startle response. They get decreased vision over time and a cherry red spot because they have preservation of their macula, and the rest of the retina is degrading, degenerating. They develop macrocephaly and often have seizures, and die by age 2 to 3 without aggressive intervention to keep them alive. And this is what normal looks like: your normal retina, optic nerve, your macula, your fovea, and what your cherry red spots can appear like are preserved macula with this halo around it where the pigmentary epithelium is disappearing. So this is preserved here and here. So black spot, but it's all the same. Depends how you're looking at it. Subacute juvenile Tay-Sachs, it's less severe. They're normal until about age 2, when they start getting an abnormal gait, losing skills, seizures, and vision loss, and they die by the second decade, unless they're the rapidly progressing type. And it's variable even within families. There's a lot of this in CNS disease. There's the slowly progressive people and the rapid progressive people. And the thought is that the rapidly progressors have some neuroinflammation. So if you could cut that down, then maybe you progress more slowly. Late onset Tay-Sachs presents in teen to adult years with dysarthria, dysphonia, poor coordination, ataxia, spasticity, and sometimes tremors, and 40% of them have psychiatric symptoms. It's slowly progressive and varies within families. All these are autosomal recessive. The MRI progression in the late onset Tay-Sachs is mostly degeneration of the cerebellum, which you can see here in a normal person. Early manifestations of the disease, it's kind of a shrunken cerebellum, and then late disease is much more severe. The diagnosis is by enzyme assay or often molecular testing. There's some tricks to the enzyme assay. You'll have low hex A and normal to increased hex B, but there are many pseudodeficiency alleles, and one of them is real common. There's also the opposite of that, where they can appear normal with artificial substrate that's used for the assays, but are abnormal when it comes to breaking down GM2, and that's the B1 variant, and there are different mutations that cause that. And then there are people that look like Tay-Sachs that don't have mutations in the hex A gene at all. It's in GM2 activator. And so they can have normal in vitro activity because you're using the artificial substrate and you're not presenting, actual GM2 in the assay, and they have mutations in GM2-2A. There are many mutations that cause Tay-Sachs. Now, we all know it because it's common in Ashkenazi Jews. It's 1 in 30 are carriers. There's 2 common founder mutations. It's also common in Cajuns. One of the founder mutations they have is the same as the Jewish associated mutation. There's an Eastern Quebec French-Canadian founder mutation, and Pennsylvania Dutch. So if you live in those areas or have Jews in your population, you potentially could face that. And most Jews get screened for this. If they're Orthodox and they're part of Doria Sharam, they get screened for this as part of it, and they don't put 2 Tay-Sachs carriers together. Sandhoff is much less common than Tay-Sachs and not as well sorted out clinically. There's an infantile form that's similar to Tay-Sachs, but often has organomegaly and can have skeletal abnormalities. And then there's a late onset form that has less psychiatric disease, but more sensory abnormalities and ataxia. Clinical trials. So that I love clinical trials and I love treating people, so I always put these in my talk. And pyrimethamine's been used. It's a weak chaperone. It probably doesn't really do anything, and the results aren't very consistent. Migostat's been used to try and make less of GM2 in the first place, so you got less to deal with. The results were poor. Vengostat is being tried right now. So that's a glucosylceramide synthase inhibitor. It's more potent than elaglustat that's approved for Gaucher disease. And this is a substrate reduction therapy being tried for late onset GM2, and we are awaiting the double-blind results. So that trial's been going on for a while now. N-acetyl-L-leucine decreases neuroinflammation, mechanism not real clear. It's being tried for late onset GM2 and for some other things that we'll talk about later. So it's kind of a generic drug that's small, it's an amino acid that decreases neuroinflammation somehow. There's gene therapy that's ongoing by intrathecal with AAV9 that has hex A and hex B that it encodes. There's an AAV8 intrathecal or a intracisternal and intrathalamic hex A and hex B gene therapy trial. In the first 2 patients with that, the results were just reported. They were more advanced patients and they seem to do a little better. So stay tuned. Turning to GM1 gangliosidosis, this is rare and autosomal recessive. It's due to beta-galactosidase deficiency. It varies from severe end with hydrops to an adult neurodegenerative disease, and there's a mutation that causes more KOB. A diagnosis is suggested by increased urine galacto-oligosaccharides and sometimes keratan sulfate, so that you can pick it up on your oligos. Enzyme assay with neuraminidase needs to be done to exclude galactosialidosis, which can look very similar. Molecular testing is what we're using most of the time to figure these things out. And it's the step prior to the step for Tay-Sachs with GM1 coming from complex gangliosides. So that's breaking down to this precursor, and it has to be cleaved further by removing this terminal galactose. Juvenile GM1, I'm not going to talk about the severe ones because they have organomegaly. It's not really a pure neuro disease. Juvenile GM1, they have onset that's a little later in childhood with ataxia, impaired gross and fine motor skills, and dysarthria. They can develop organomegaly, cardiomyopathy, and corneal clouding over time, but they'll present in neuro first. Short stature, plus or minus dysostosis multiplex over time, and they're at risk for odontoid hypoplasia, which needs to be dealt with. Otherwise, they'll cut their spinal cords. And they develop cerebral atrophy and they die in their second decade. The later onset form, the chronic adult, presents in late childhood to the third decade with dystonia, unsteady gait, and they may have psychiatric symptoms like a lot of these later onset CNS involving diseases with speech and swallowing problems. They are short and they may have mild dysostosis multiplex on their x-rays, and they may develop a cardiomyopathy over time. And this is the brain MRI of a child with the late infantile form. So starts off with minimal atrophy. The atrophy gets worse, and you can see enlargement between the cerebral folds and the ventricles, but you're also getting iron deposition that's occurring in the basal ganglia. That's also a common feature of some of these CNS degenerative diseases is iron deposition in the brain. There are some treatment trials. There's a gene therapy with 2 different intercisternal AAVs in kids up to 3 years of age, and there's an IV AAV9 in 6 months to 12 years of age. There's no results yet. Substrate reduction with venglustat is being tried as part of the Tay-Sachs trial. It's a secondary population that's open label. We've got a bunch of different things that we're treating and seeing if we make any difference. And I've got somebody with sialidosis who's showing a pretty damn good response. So I'm hoping Tay-Sachs will turn out to be similar, the adult Tay-Sachs, and they'll do well, but we'll see when the blind is eventually broken. So metachromatic leukodystrophy is another one that we deal with, and this is autosomal recessive deficiency of aryl sulfatase A. They have storage of sulfated lipids in their central and peripheral nervous system. It can have onset from infancy to older adults. The diagnosis is by enzyme assay, but there's a big caveat to that. Urine sulfatides and molecular testing. And the caveat to the enzyme assay is there's a common pseudodeficiency allele that's homozygous in about 2% of the population. It can be insist with a pathogenic mutation, so you can't just, test for that one mutation and say, it's a pseudodeficiency. It's a pan-ethnic disease, but there's a founder mutation in the Inuit and the Western Navajo. So the deficiency in MLD is this aryl sulfatase A that breaks down this this sulfated galactosyl ceramide. And then the next step is what's broken down by the enzyme that causes Krabbe disease. We'll talk about in a second. So MLD, you could do newborn screening for, but you're not going to do an enzyme assay with such a high pseudodeficiency rate unless you love doing second-tier molecular testing or sulfatides. So sulfatide may be what is actually screened for in the newborn screening when it comes down the pike. And given the fact that there's a treatment for this that's approved in Europe, I think that would be better sooner rather than later, because unless you've got a prior affected SIB, you're going to be picking them up too late. Late infantile MLD has an onset of under 30 months. Hypotonia, weakness, toe walking, and slow nerve conduction, and they regress and show spasticity, pain from their neuropathy, and seizures. And juvenile MLD is later than that, and they decline in school performance. They have gait problems, and neuropathy, ataxia, seizures. They're much slower progressing. And then there's adult MLD, which can present as a psychiatric disease. So most psychiatrists know to look for this when they've got somebody who's previously been okay and then is acting like they're psychotic, schizophrenic, something like that. They may develop spasticity, seizures, and peripheral neuropathy, and it's slow and has a variable rate of decline. The MRI, when it gets to that point and you've got degeneration of your white matter, you get these tiger-like lesions or leopard skin lesions in the white matter. You can see these little lines that are in here of loss of material. So that's pretty characteristic for MLD when it's advanced enough. The treatment has been hematopoietic stem cell therapy prior to the onset of symptoms or very early in the course for a juvenile or adult MLD. Now there's an ex vivo hematopoietic stem cell therapy with a lentiviral used to insert the gene into the genome, and you give the person their own bone marrow back after you've ablated them. It's been approved in Europe. It hopefully will get approved here soon. It needs to be given early for the people that are going to respond. There's also intrathecal enzyme replacement therapy in trials. Now, the role of this versus hematopoietic stem cell therapy, at least the consensus, I think, of the bone marrow transplant people is if you've got an HLA identical match, use that. That's not a carrier. But if it's you don't have that kind of match, then this would be ideal because you're not going to get graft versus host disease, and it's probably going to work better. There is one kicker to all of these lentiviral hematopoietic stem cell therapies, and that's there's random integration of your transgene, and there's been cases of leukemia. So it's not a completely benign thing to do. Aside from the transplant, you may end up with problems later. But here's the results. This just came out. This is the 3-year extension data on the patients with late infantile MLD, and these are people that were, either asymptomatic to begin with or minimally symptomatic, and early juvenile MLD. And these are gross motor functional scores. And the people that are doing well are the ones that have gotten this treatment, this ex vivo gene therapy, compared to their natural history cohort, which is doing terrible, as you'd expect. And the early juveniles, they progress more slowly, but still the difference is pretty striking. And I'd say I think this is better than most bone marrow transplant results, but it remains to be seen whether this would be preferred to a HLA identical match. I'm not sure, given the issue about cancer. So Krabbe disease is the next step in that breakdown, and it's a autosomal recessive disease. It's about 1 in 250,000, depending on the population. It's a deficiency of galactosylceramidase, and it has infantile to older adult presentations. Diagnosis is with an enzyme and molecular testing. There's a common 30 kb deletion that comprises 45% of pathogenic alleles in the newborn screening that's done. But there's also a lot of pseudodeficiency alleles that are common. There is some genotype-phenotype correlations, but even then there's variability once you get beyond the most severe mutations. Now, something that you can pick up in someone with Krabbe, at least the infantile one, is this galactosylceramide that it isn't able to be broken down into ceramide because of a deficiency of that enzyme. Can be degraded. There's an enzyme that does this for all of these sphingolipids. Is you lose one of the fatty acids and you make a sphingosine derivative. So this is galactosyl-sphingosine, otherwise known as cycosine. And that is a metabolite that you can pick up on blood spots. And so what we're doing, and a number of states are moving towards it, that are screening for Krabbe, which still isn't on the recommended uniform screening panel, is to use cycosine as a second-tier test if your enzyme assay shows low enzyme activity on a blood spot. And if your cycosine is normal, it's most likely a pseudodeficiency, and we don't follow them up. If it's comes back a little elevated, then you're not quite sure what the onset is, and if it's above 10, then it's probably a infantile one that you need to hustle in for transplant evaluation, because that's the treatment. So early infantile Krabbe has its onset less than a year. It's actually less common on the newborn screening than the later onset is by a lot. They present with extreme irritability, developmental delay, and they progress into spastic and pretty miserable kids. If got a peripheral neuropathy, if they're not put on a ventilator, they often die by age 2. And they have little to no enzyme activity and have 2 severe mutations. They have elevated CSF protein, and their cytosine, at least in the newborn period, is greater than 10. And they start off with a fairly normal MRI, and then they begin to show loss of white matter over time, and a leukodystrophy that becomes more obvious, and then and atrophy at the same time. Early childhood Krabbe's, a little later onsets, they have slowed development or regression, and they may develop esotropia and vision loss, seizures, and they get a neuropathy. They have abnormal nerve conduction like the infantile ones do. Bears and visual evoke responses. Then later onset Krabbe, they may present with weakness, behavioral changes, decreased sensation and burning paresthesias, and they may not even have increased cytosine. So it's not a terribly good biomarker for following people, and they slowly decline. So the treatment is for the infantile ones is hematopoietic stem cell therapy prior to 1 month of age. Now the results are not perfect. So if it's a kid that you can get in a transplant very fast, maybe even deliver prematurely, a few weeks early, you can do better. But the results are mixed, and kids may maybe need G-tube fed, and they may not walk. It's not a great outcome, and that we've got right now. It just takes time for the cells to migrate and set up shop in the brain, and that's time these kids don't have. It's ideally done pre or early symptomatic for the older patients. So that's, since we don't have a great biomarker to tell us when that is, that's an issue. There is a trial of intravenous and intracisternal AAV enzyme gene therapy, rather. Newborn screening is done in some states, where we've got a pilot program in Georgia. It's been difficult. New York has the most experience by far, due to pseudodeficiencies and variants of unknown significance. And we just went ahead and do cytosine second-tier testing to get out of that molecular nightmare. And cases that aren't predicted to be early infantile need to be followed, but many are lost to follow-up. That's been the experience in New York, and that's not encouraging. We actually picked up one not too long ago, and it was predicted to be infantile, and got them in for transplant evaluation, and our transplant people who've dealt with transplants in Krabbe before have had a discussion with them, and they checked around, and they elected not to treat their kid. They were also given the option of traveling to try and get in the gene therapy trial. So they elected not to do anything, which is what some of the families are doing. So what we do with the later onset ones is a lot tougher. So there's some reasons this isn't on the RUSP yet. Mucolipidosis 4 is autosomal recessive. It's more common in Ashkenazi Jews, and there's a founder mutation that's a deletion, and also another one that's a splice site change. They get accumulation of multiple lipids and GAGs in their lysosome, and it's due to a deficiency of mucolipin-1, which is a transient receptor potential cation channel. So that doesn't mean anything. I'll show you what the presumed pathology means. They present with delayed development. They develop retinopathy plus or minus corneal clouding. They can not make acid in their stomach, progressive kidney disease in second to third decade, and rare milder cases can have isolated retinopathy or ataxia. So the natural history, that's what your normal development is supposed to be like. They will show some development that's slower, and then they plateau, and then they degenerate when they're older, and losing their vision over time. What you'll see on the MRI over time is undermyelination, and then atrophy and deposition of iron and basal ganglia. The cerebellum is what gets hit the hardest, corpus callosum. The proposed pathogenic mechanism is a loss of moving iron out and not moving calcium out of the lysosome. So you get the iron storage problem. And then the lack of the calcium efflux leads to problems with autophagosomes, problems with exocytosis of collections of junk in your lysosome that you don't want anymore. You're able to move that stuff out of the cell. And failure to even make enough lysosomes. Now, it's something that was interesting. It hasn't gotten into people yet, but it was something done in mice. They're a small molecule agonist of the 2-pore channel, the TPC2 protein, leads to decreased storage and improved function in the ML4 mice. In vitro, they tried it for Niemann-Pick C1 and CLN3 Batten disease cells, and it did the same thing. What it does is it stimulates autophagy and exocytosis by stimulating this protein. So, that would be cute if it actually works, that you're able to kind of correct some of the problem and deficiency of mucolipin by stimulating TPC2. So stay tuned. I'd be shocked if it didn't go into human clinical trials, because this paper was really detailed on its use and how it works. A large category of disease that you may see and neurologists see more of is neuronal ceroid lipofuscinosis, or Batten disease, as a generic term. And these are neurodegenerative disorders with an autofluorescent storage material. It's made up of lipids and other proteins, including one of the cytochromes. And it has its onset from infants to adults with seizures and regression. Some have retinopathy, which may be the only problem in the milder patients. There are 13 different genes. All are recessive except for one dominant type. There's some of them that are enzymatic deficiencies, enzymes in the lysosomes. Those you can assay, but most people are doing molecular panel testing for seizures to try, and then they end up finding this, which isn't exactly when you'd like to find them. You'd like to find them earlier, but that's the way it is right now. So the one that there's treatment for is this tripeptidyl peptidase 1 CLN2 disease. So it's something that breaks down small peptides in the lysosome. There's a few other enzymatic defects like CLN1, which is much more rare than CLN2. And there are some cathepsins that are also cause some of the rare types of NCL. So here's a CLN2 that shows how they progress over time with abnormal myelinization on their FLAIR imaging, progressing here and and just lack of good myelination here. And then they start to atrophy. And here is progression showing atrophy over time. It's more in the cerebellum than other places. There's different treatment approaches that are being tried. The only one that's approved is an enzyme replacement therapy, which has to be given into your brain periodically, and that's for CLN2. That's cerlipinase alpha is the drug name. There's plans for CLN1, and then there's, hematopoietic stem cell therapy has been used for a few, mostly in animals, and there's gene therapy that's in various stages, and some pharmacologic therapies like that leucine, acylated leucine amino acid that's supposed to decrease neuroinflammation. Interventricular ERT for CLN2 has been around for a little while. It delays onset of symptoms in pre-symptomatic kids. In more symptomatic patients, they often progress anyway, so it's not clear it's really beneficial to them. And there's a publication that came out this year that their retinal disease progresses in spite of therapy. It costs a lot, and it's not that easy to give because it has to be intracerebral or interventricular. But I was looking at the expensive drug list, and it's about the same price as glycerol phenylbutyrate, which is obscene. This is, enzyme replacement that has to be manufactured in a difficult way, and there's not that many patients, and glycerol phenylbutyrate ain't that hard and isn't that expensive to make. So it's kind of gross what some people charge for some of our diseases. Niemann-Pick C is a autosomal recessive neurodegenerative disorder. It's really variable. It's a defect in intracellular cholesterol transport, and that leads to sphingosine storage, which is why it would ever get lumped with Niemann-Pick A and B, and decreased cholesterol esterification, which leads to abnormal membrane dynamics and signaling. It's infantile to adult onset. They have lipid-laden macrophages, and eventually they get atrophy on their brain MRI. You can suspect the diagnosis based on elevated oxysterols, which are done at Mayo. You can get them done fairly easily. Abnormal Philippin staining on cultured fibroblasts was the old way that we used to do it, because there weren't biomarkers yet, and that was about all we had, trying to figure out what they had. But molecular leads to it most of the time. And there's two different genes that cause this, and the NPC1 is by far the most common of the two. And there's the earliest ones get liver disease, and that often can be fatal. And then the later infantile, juvenile, and adult get more of the neurodegeneration problems. The adults get psychiatric disease, and they can all have seizures and ataxia, and some of them get splenomegaly, but they don't have to. So they don't have to have any overt storage that you can pick up. So the problem here is altered cholesterol trafficking. So normal cholesterol, unesterified cholesterol, comes in through the endosomes, fuses with your lysosome, gets directed towards Golgi and the plasmic reticulum, and then gets esterified there. whereas you can't do any of that with Niemann-Pick C. So you just aren't transporting it where it's supposed to. So it's accumulating in your lysosome, and importantly, you're not esterifying your cholesterol. So potential treatments, miglustat's been used for years. That's a glucosylceramide synthase inhibitor, the first. It inhibits disaccharidases, which is why you get diarrhea with it. It seems to increase survival on average. It improves their saccadic eye movements. It's approved in some countries. It's used off-label in the US. It's expensive. Ramipromol is in expanded access right now. The company's kind of struggling financially. I don't know what's going to happen with it. It increases the amount of HSP70 chaperone you have, and in a phase 2 double-blind trial, it slowed progression over a year. And the Niemann-Pick mavens, which I'm not, thought that's good enough, and they should have gotten licensed, but the FDA went, no. So it's not clear what their regulatory path is. They're kind of expecting too much. There's other things I could point to where they're much too loose with what they're doing, but not Niemann-Pick C. They seem to be very anal about what they're willing to accept as proof of clinical efficacy. N-acetylleucine, which is we discussed before, is a decreaser of neuroinflammation. There's an open label study that showed clinical improvement while they were on therapy. And then when they went off of it, they deteriorated back again. And it's now in phase 3 trials. So you're supposed to get rapid improvement. I've signed up to do this study too. So that would be great if you can, just cutting down neuroinflammation can improve them. I'm not sure it's going to stop it from progressing, but if it helps, that's great. There's different attempts to use cyclodextrins, and I'll show you how those work in a minute, to slow disease progression or arrest it. So there's an intrathecal trial that was done to slow it in a phase 1/2 trial that's published. There's an IV form of it for liver disease that's being done at WashU. And there's a large dose of cyclodextrin that's IV for the CNS disease that's going into phase 3 that I'll be doing too. So how does this cyclodextrin work? So it's this ring-like structure. It's hydrophilic on the outside and hydrophobic on the inside. So you could well imagine that cholesterol would like to sit on the inside of this. And that's the idea, is the cyclodextrin captures the cholesterol and then can shunt it around in the cell, because this thing cyclodextrins penetrate the cells. The quantity that they're talking about for treating patients with IV is like grams of the stuff with each infusion. So it's a lot. But, it doesn't seem to be toxic. So off we go. So that's all I got, unless, next year you can let me know if there's some other diseases you want me to throw in here, because it's clear I still got time that I could go on next year. So send me an email if you want me to take on some other diseases. And now I will see if you got any questions.
Thank you, Bill. Any questions for Dr. Wilcox? That was great, comprehensive information about CNS-related LSDs. I'm curious myself if you see the future with gene therapy being better than stem cell replacement. There's stem cell therapy and ERT, or is it going to be pretty similar in terms of efficacy for most of these disorders?
I mean, the advantage of the gene therapy directed at the brain is you're not integrating into anything. These cells are post-mitotic for the most part, so you're not worried about them diluting and losing the transgene, maybe. And you can get it in really fast. The stem cell transplant, you're basically talking 6 months before those cells have really set up shop and set out their little fingers through their microglia to begin helping out their neighbors. And that's time that these, once you're picking them up and they're symptomatic, you just don't have that kind of time. You want to stomp on it as fast as you can.
Mm-hmm.
So to me, it seems like treating the brain directly is better. And maybe that's not going to be the long-term answer, or maybe transplant is. So it could end up being a combination of those if it's not ridiculously expensive.
Do you know studies that are using combinations of either gene or stem cell therapy and the anti-inflammatory, the N-acetyl-L-leucine?
No. I mean, we haven't gotten to the point where we've proven one of these things works great in the long term.
Kitchen sink at it.
Yeah, it's just all of these things are expensive too, and these companies are, it's not the same companies, so there are different companies that would have to play with each other, and they don't.
Right.
Yeah.
And there isn't like some national coordinating center for these things like there is for cancer, where everybody's part of these protocols and you can throw these different very expensive drugs at them. It doesn't work like that for us.
What a world that would be, huh?
Yeah, that would be amazing.
Could I-
Or where we
I-
could even do head-to-head of drugs that we've got for different diseases and know which one's the better option.
Dwight, go ahead.
Oh, sure. Yeah. I was going to chime in. I mean, and it's well known that the hypothesis is that, transducing stem cell that goes to the brain that overexpresses the enzyme and you can achieve cross correction might be more efficacious than just hematopoietic stem cell transplant. And there are preclinical, like Bill was saying, there's preclinical data for lots of different disorders that suggests it works that way. Isn't it MPS 3 where the trials with lentiviral therapy, transducing stem cells have really advanced in Europe? Is it approved yet for
Well, I don't know that.
Okay.
What the status is in Europe. I've seen some of the data for the MPS.
Yeah.
There, if the patient is a slow progressor, that may be a very efficacious therapy, and you can deliver far more enzyme using the lentiviral approach than you could with just a regular stem cell transplant.
Yeah.
And that might be better even if you've got the risk for leukemia. But for the patients who are rapid progressors and are declining, they don't do well.
Yeah,
they just
regardless.
deteriorate. Yeah, it doesn't matter what you do. Maybe if you hit them with something that stopped neural inflammation, you could buy them the time for it to work.
Safety is supposed to be much better than for those early trials in SCID where they had a high rate of leukemia. I mean, even in those, they were able to treat those patients.
Yeah, but it's happened. I had this
Okay.
discussion with our bone marrow transplant people. They're much more involved with treating thalassemias and the like, but it's happened there. So
yeah, it's probably not completely solved. Well, Bill, let me really pick your brain. So how are we going to solve the high cost of orphan drugs? Is there any hope?
Well, is there any hope of solving the drug pricing for the rest of us who have common diseases? If had their first, they tipped their toe in the water for Medicare for some things. You know, the other side is just screaming bloody murder that should go away and they should raise those prices back again so the drug companies make their fortunes. You know, they have to make their money. I mean, let's be real. It costs $100,000 plus per patient per year to do a clinical trial in our area. It's just tons more work. Recruitment is a total bitch, and they've got to have lots of sites to do most of these things. So for most of it, it's terrible. But for things, you know, why should sodium phenylbutyrate cost so much when it was Saul Brusso that worked on this forever?
Yeah,
You know, some company comes in, gets a patent and jacks up the price, or
that's a case.
tetrahydrobiopterin.
That's a case for legislation. That really shouldn't happen. I don't know, but
you know, even when there's competitors, the price doesn't go down much. It's still obscene, and that is, you know, I think they have to factor in what did you actually put into this? What does it actually cost to make and market? And how much of this is just pure profit? And what are you doing with it? So are you just, you know, making your stockholders rich, or are you investing it in the next therapy? So I'm fine with people investing in the next therapy. Otherwise, we wouldn't have it. These companies are not going to be interested in doing this unless they're going to make money. That's why Mega Pharma has never been particularly interested until now in this stuff. And they don't do a very good job at it when they are. It's better the small companies get involved first. So I wouldn't want to kill the golden goose, but at the same time, something needs to be done about the things that shouldn't cost that much.
or we'll run out of money. Nothing will be paid for.
Yeah, well, they're beginning to scream about it. So there's now more healthcare economists that are looking at the cost-benefit ratio of these treatments. And for example, should you treat an NCL2 with this enzyme replacement if they're already pretty symptomatic? The answer is probably not, because they're going to progress anyway. It's just you're wasting your money. But can you imagine telling a family that? But in nationalized healthcare systems, they would. They'd say no. But here, you know, maybe we should tell them, let's give it a try. And if it doesn't make any difference, let's stop, because it's a pain in the butt to be giving stuff into people's brains. You know, I've seen a Gaucher type 2 transplanted, which is just horrid. The result of that misadventure was just sickening. And the kid was symptomatic, obviously, because they all are, when the transplant was done. So we get old, we start bitching, huh?
It's good insight and good experience, and definitely issues that would be great to tackle. But yeah, in capitalist society, it's probably not going to be done without socialized healthcare or national health.
Yeah, well, you wouldn't get these things if it wasn't for the capitalism. Even
Yeah.
you know, Dr. Biffy in Italy, who's doing a lot of this ex vivo lentiviral things. You know, she's got some funding from the Italian government, but a lot of it's coming from industry. If they didn't have a chance of making a lot of money, they wouldn't do it.
Mm-hmm. Anybody else? Questions for Dr. Wilcox?
I mean, this is exciting times. That there's even a possibility of treating Niemann-Pick C when Yeah, I started out, it's like even diagnosing the patients was difficult.
It's really painful to see those patients deteriorate.
But we're moving things along, and maybe there's hope to at least slow things down for these god-awful diseases. That's why I stay in this, plugging along. And for any biochemical people, if you haven't been involved in clinical trials, get yourself going, because it's the way to move things forward and help out our patients. It takes resources, which is the issue. Once you get up to a critical mass, then you can do more and more of them, which is where we're at.
Yeah, I'm curious, Bill, how did you guys get to the point where you had enough resources from your institution to have the infrastructure to sort of, start up and recruit and do all the things that you need to do for clinical trials to make your site attractive?
So at Emory, it began with substantially better funding from industry for clinical trials. It's the same thing I experienced at Cedars. Better funding for a clinical trial where you could get them to give you 1% of your FTE. They don't do that anymore. They just say, I mean, maybe if you're lucky they will, but usually they're telling you how much per patient. They're trying to nickel and dime you to death. So you got to stand up for yourself with the budgets. And trying to build it from scratch right now, if the institution is interested in supporting this, great, because you're going to need it to start out before you got enough trials. And you always need, some buffer money to support the people in between trials. You can never completely fund them off of an active trial. What helps is the registries. So the post-marketing registries pay you for entering data for things, and they pay you enough that it's helpful for making up for what the clinical trials are not always covering. So you've got some money in the bank, or at least in your accounts receivable, so that you're in the black. And we have to be in the black at Emory. We don't get the deficit, spend. My administration would get very pissed at us now if we are not running in the black. We've gotten a little bit of money from them recently, and a little philanthropy to get a regulatory specialist to try and push things along faster and take on some more stuff. But we can't count on them to pony up much of anything. So yeah, it's hard.
Do you have intra-institutional competition with other specialties? I mean, for a lot of these disorders, our neurologists have sort of cornered the market on clinical trials, and they have the infrastructure that we don't have. Some institutions
that's
probably more collaborative.
It's exactly the opposite at Emory. So we have more resources for doing things than most of the pediatric subspecialties. And so they don't take on a lot of things that they really could, and it's wide open for us to step in there. Plus we cross adults and kids. And we're not under children, so we're a separate department at Emory, and run it through our system and just get budget items and collaborators over at Children's to get the stuff done, or outside of Children's if that's necessary. We have people in private practice who we can work with many of these things. So it's kind of cobbling things together, but we're not really competing with them for most things. Cancer, that's their own little. They're well funded, but in the adult arena, a lot of them don't have good infrastructure either. So we're able to really step in if we can identify the patients and take this stuff on. We just have to decide what we want to work on and what's appropriate. And if I can't ensure that I'm going to get at least a couple of patients enrolled, it ain't worth it. It's too much effort.
It's a good system though. So.
And it helps to have really good people.
Mm-hmm.
Like, our head coordinator is Dawn Laney, and she's junior faculty. That's you can't get better people than that.
Yeah, we've had a ton of turnover with our research personnel, so it's clogged up a lot of things.
Yeah, that really will kill you.
Yeah.
The big problem that we have, I mean, this is totally off topic, is providing clinical service using research dollars. Where the healthcare isn't providing enough to take care of the patients. Because we don't have extra money.
Mm-hmm. Yeah.
Kind of on that vein, in terms of like, it's okay. The kind of like financial piece and economic side of things. So I'm kind of in the preclinical gene therapy world. I'm just now stepping into the clinical side. So all of this stuff is new to me, the big pharma stuff, and all of the costs involved with all of these therapies that are very expensive. And, of course, with my background, I'm very hopeful about gene therapy and in hopes that it will be like a one-time treatment to mitigate a lot of these like recurrent costs of enzyme replacement or whatever. What have you guys seen in terms of, or I mean, I guess this would be hard to predict in terms of insurance coverage or affordability of a gene therapy should it come to market for, again, we talk about these orphan disorders and things like that, and how it's incredibly, tremendously expensive to fund these efforts to begin with. There needs to be a profit, so on and so forth. It's the most expensive drug in the world for SMA at $5 million. I mean, what are kind of your thoughts on all of that, Dr. Wilcox? I would love to kind of hear your perspective.
Our institution is like a little over 2 for SMA for the kids on newborn screening. It's a struggle to get not get it paid for by even Medicaid. It's a struggle for the hospital to be willing to lay out that kind of resource and get paid later. So they've had to, because they don't like that kind of bill on their accounts receivable. So they have worked out a deal with the payers to do something where they're not fronting all the money. That's something the company has to work out too. And some insurance companies may want a clawback. So, if the patient's not doing well, the gene therapy is not really lasting, and they've got to go back on something else, you got to pay them back. You don't get to charge them that $2 million plus. But it's not clear that they're going to make ends meet just on the $2 million. These things are expensive to manufacture. Insanely expensive to manufacture to GCP standards. If they're ex vivo gene therapy, it's, you're taking your patient's cells and you're doing the transfections. You have to do that all under GCP conditions. So with all the money that gets spent, often the whole clinical program from the time you've entered into manufacturing and doing clinical trials 8-10 years, that you're spending money and not making any. That's a lot you've got to recover, even if the trials are not huge numbers. It tends to be a few sites. So it's hard to see how the economics of this are going to work out. And some companies have decided, like Amicus, that we're just going to peel that part off. We're not going to keep carrying that on our books because it's too expensive, too likely to fail. Yeah, get somebody with deep pockets. And you can't do this academically. There's very few places that are so well funded with philanthropy that they can do their own gene therapy and move it, at least get through the phase 1/2 trial to get industry partnership. That's a lot of money. There's very few places that can do that.
Yeah. I'll echo that. My experience was I could get NIH funding for the clinical trial, phase 1 clinical trial. I could get collaboration to talk about manufacturing vector through NCATS, but the only way to go ahead was actually to find an industry sponsor to do the manufacturing. Just couldn't get it otherwise, and the rest of the trial was planned and prepared entirely in academia, but we really needed industry to manufacture. It's too specialized, too expensive. Maybe it'll change.
And there's contract companies that'll do it now, but that's still, where are you going to get that big pile of money from?
Exactly.
Thank you. It's some great insight into the realities of the reality. Yeah. Thank you very much.
You got to learn this stuff in your training too.
Yeah. No, it's very not often talked about, but very important.
All right. Well, nice not seeing everybody, but
thanks again, Bill, Dr. Wilcox, and we will be talking with Dr. Coughlin next week. So stay tuned, and thanks again. Everybody have a great weekend.
bye-bye.
Bye.